All right, we are live on Facebook. Good afternoon, everybody. It's great to see you. Thanks for tuning in for our double header this weekend. This afternoon, we have Keith Wages with us. He is a retired state director, and we are fortunate enough to have him on our board as well here at the museum. So I'm going to turn it over to President Dot Clinchy. I'm going to poke the dog out of the way, and we'll listen here to see what Keith has to say about his journey in EMS.
Great. Good afternoon, everybody. Hi, Keith.
Hello.
I'm just going to ask a few questions, and you're going to do most of the talking over the next 30 minutes or so.
Okay.
I think my first question is one that I already primed you on, which is you got an undergraduate degree in agricultural economics and a certificate in public management. I'm curious as to how the trail took you from that undergraduate work to becoming an EMS management guy.
Okay. When I was in high school, I had a phenomenal biology teacher who wanted to show us not only the principles of biology, but how it was used in practical application. So she had the local EMS director come and do a class. I was probably about 15 years old when I saw this, and he came and he talked about the EMS profession. And I thought at that time, I said, you know, that would be a perfect way for me to work my way through college. I would get some real life experiences. I would have a flexible schedule, be able to, to work my classes around. So that's when I started thinking that would be my college job. So I graduated from high school at 17 and started at the University of Georgia, and immediately as soon enrolled in the EMT program and took it while I was taking college courses. And then I got a job at the local EMS organization, and I stayed there during the rest of my college career. I majored in agricultural economics because I grew up on a farm here in Northeast Georgia, had an interest in it. It was a broad curriculum, opened a lot of doors outside of agriculture. You take the same finance and accounting and that sort of thing. So that's why I majored in ag econ. And when I graduated, I was pondering my opportunities, and the first job offer that came my way was a nearby hospital had a department head position open, and he was friends with our department, with our hospital administrator where I had been working at a hospital-based service. And he said, I got this guy, he just graduated college. I think he'd be just the right fit for you. So they call me up, I go over, I meet with them. And a couple of days later, they hire me as their department head for EMS and other type functions, disaster planning and that sort of thing. A lot of people back then wore different hats.
Sure.
And so that was how I got into EMS administration. I did that for 2 years, and the regional EMS director position it was then the Department of Human Resources came open. I had been on the council. I knew everyone in the region by that time. So I was hired as the regional EMS director, stayed there 7 years, and went to Atlanta about the time I turned 30 to be deputy director, and then shortly thereafter director. So it was a pretty straightforward path from local EMS director, regional EMS director, deputy, and then state director. That's it. And that all happened in about 12 years. But I've been in EMS my entire adult life. I started when I was 18, and I've done something related ever since.
And you started with a hospital-based system when you were doing EMS.
I did, and then the system I managed was hospital-based. So that was where the one I started with was sort of transitioning to a third service before I left. So it was sort of a hybrid model that last year or so. So I had an appreciation and understanding of third service and working with local government, county government, and that sort of thing. But I've always described my primary experience being that of hospital-based, at least on the delivery side.
Good place to learn a lot, isn't it?
Well, it is. And I've always said I learned more in the emergency department than I did anywhere else, because during down times, you're able to interact with the physicians and the nurses and all of the ancillary professions of lab and x-ray and respiratory therapy. So it is a great pod for education, particularly when I was young and wanted to learn and had a great interest in and by that time, I had decided that to make my career in EMS, or at least for the foreseeable future. And I knew that there would be some opportunities down the road. I didn't know just exactly the path, but it worked out.
Well, the profession has matured, hasn't it? So there's a lot more to it now.
It has matured, and I saw a pretty significant difference even from the system that I left in the 90s, 2000-ish, to the one that I came back to in 2010. I was still involved with EMS and emergency management, but it matured. It matured a fair amount in those 10 years. But over the 40 years, amazing change, and evolution. Yeah. No question.
I look back, for example, the BLS squad that I was chief of in Pennsylvania doesn't exist anymore.
Yeah, sure.
It was all volunteer in those days.
Right. I spoke at a ambulance service banquet, EMS banquet, at their 40th anniversary, and so I guess this was 10 years ago or so. And I talked about, I've observed all the changes that had taken place since they started, and it was really, we saw change in ambulances, we saw change in equipment, and we saw change in the caliber of not the caliber, but the capability of the personnel.
Yeah.
Medics are just more advanced, smarter.
Yeah.
It's great.
So during your time as the Georgia director, and I think you said it was 1990 to 96, you were director.
The first time, yes, sir. Mm-hmm.
What are the things that you implemented that people ought to be aware of from the standpoint of system improvement?
I think the most significant change we made probably during that time frame was electronic data collection. It was all, prior to that, it was all handwritten reports collected, but no way to manage that data, no way to collect it, collate it. It was just really the submission was useless. But we created an electronic format and started collecting data. Now if we looked now back at what we were doing then, we would consider it obviously obsolete, because it is obsolete today. But it was the best available to us at the time. It was a scannable report. So I think create, and we did it with the EMS community. That's not to say everybody liked it or supported it, but we did it with the stakeholder engagement. They led the process, drove the process, and that group of stakeholders signed off on the final products. And so I think that was probably the most significant system-wide issue. We were just getting into trauma system. That was really the first of the systems of care that started developing. But those really, while we designated them, those systems really hadn't matured yet. So, we were trying to improve things like our education system and our certification process. I guess the other thing that happened in that time frame is we transitioned to National Registry as our certification mechanism. So That was pretty significant. Georgia is still a national registry state. And so system-wide, I would say data and national registry were our two big ticket items in that 6-year window.
National Registry initially got a lot of resistance, but what I tried to explain to my paramedic students years ago was you will have mobility. If you want to go from point A to point B in a different state, you've got a card in your pocket that's going to be recognized in that different state.
Absolutely. We used that motivation. We also we talked extensively about the importance of having a test that was credible and a certification that was reliable and defendable and that sort of thing. Owning your own test is very expensive and very difficult. And we really, and we made it clear that National Registry was not a vendor; they were a partner in the process. And the second time around, for me in Georgia, we have been advancing that relationship with National Registry, with the national scope of practice, with all of the national standards, and you know, with the message that we all share a responsibility in maintaining a sustainable workforce, a competent and sustainable workforce, and that is everybody has a part in that. The student has a part, the schools, the test has a part, the background check that we do, the FBI background check that many of the states are doing now, including Georgia, and then the employer orienting the employee appropriately when they go to work, and then making sure that we have, and I think maybe more than competency on the front end, I think continued competency may be a greater challenge for us than initial competency. Yeah. Because we don't all have the same continuing ed opportunities. We don't all have the same work experience opportunities. So there is an element of rust out that takes place, skill degradation when you're not able to keep those skills up. Those are some of the challenges, I think. And I think the only way we're going to successfully address those challenges is together, everybody doing their part. It's not a linear solution or a unilateral solution. There's nothing any one group can do to achieve that, I don't think.
Sure. And I'm nuts. Sorry, I've got to put my phone on mute, dummy. Hang on. Sorry.
No, not at all.
One of the things that years ago, at the same time I was chief of that BLS squad, I don't know whether chief or president at the time, I forget which, but I served on the board of a community hospital. And Lehigh Valley Hospital Center opened up, and they had medevac, a flight program. And the attitude of our board members who really didn't understand medicine and emergency medicine said, well, they're going to steal patients from us. And I said, we don't want those patients. We can't handle those patients.
Right, exactly.
They need to be in a level 1 trauma center. Did you end up and encounter any of that kind of resistance in Georgia with flight programs and so on?
Oh, absolutely. And still to this day, there's hospitals that are fearful of those standards. We saw a particular concern in cardiac facilities, looking at when we were embarking on designating cardiac centers. That's a very competitive marketplace. Yep. I would say, on a very positive note, I think that I don't take credit for this, but it happened in the last 10 years that I was state director, was our work with a stroke system of care. And that, if I had to point to one thing that was my greatest source of pride, I think it would be how we progressed in stroke care. Because when you and I started our careers, stroke wasn't even an emergency. It was just, there was nothing you could do.
Just happened.
Just happened. That was it. But now we know that there are things we can do.
Yeah.
And we still have an amazing neuroscientist at Grady and Emory, a gentleman by the name of Dr. Michael Frankel. Dr. Frankel is from Louisville, Kentucky, but came to Emory, did his residency, and never left. And he is an absolute blessing to EMS and to stroke care and to his community. He's a wonderful human being on top of being an amazing neuroscientist. And so he took up the cause to develop a system of care. And we had a group called the Georgia Stroke Professionals Alliance, and that was predominantly nurses, but others, all were invited, physicians and EMS personnel as well. And so that was, I've always said that every really successful system starts with at least one passionate advocate who has credibility both in the profession and with other policymakers. Then a group of dedicated stakeholders who are willing to work together and not in opposition. And that was the case with the stroke hospitals. They weren't competing with each other. They were putting aside their competition and working together and supporting one another. So legislation flew through the process with a great spirit of camaraderie and cooperation, collaboration, and then we started seeing, I think, the final leg of any great system is when EMS and hospitals are working in sync with each other. There's not a barrier between those two, and we had that with stroke. So I think that's why we made so much progress with stroke, where we have had more barriers maybe with other systems of care, such as what you were talking about competition for the patient, keep the patient versus send it. There'll always be some of that, but stroke was one where we got beyond it more often than not. Still work to do though with trauma, I think, and cardiac.
Yeah, but I think the survival of trauma patients today is remarkably better than it was 40 years ago. I mean, because 40 years ago, when I was a young firefighter, we just threw them in a Stokes basket, put them in the back of the police wagon, and said, "Go like hell for the hospital." I mean,
right. We're definitely doing a better job of getting them to the right place at the right time.
Sorry, that was 55 years ago. I'm sorry.
Oh wow. Yeah, now that was a very different, sure enough, a different environment.
Oh yeah.
Yeah.
Yeah. We didn't know much. So stroke is an area where you think we've made some major inroads. I think from my experience as a paramedic, I would say also in cardiac care, we've vastly improved survival rates because we've gotten better at recognizing the problems and early intervention.
Right.
Same with stroke. Is early intervention, I think, is the key.
We noticed as we really dug down into the data, we noticed that when we were missing that window of opportunity for intervention, was when the patient was not activating the system soon enough. And we realized that one of our initiatives had to be to get the community understanding the importance of activating 911, and then getting to the right place at the right time with the right care by the right means. And so it takes everybody's fulfilling their role, and starting with the patient or patient family to get the system, because that window starts with the onset of symptoms, not when 911's called. So and same with cardiac, early recognition, early notification, all of those are critical elements to having an improved outcome. And I think I agree with you. We've made tremendous progress.
Yeah, and I think, Keith, some of the aspects of it that I've seen are not only what the pre-hospital care provider can do, but how they're tied into the healthcare system to whom they are taking patients, and then your telecommunicators and
Absolutely.
asking the right questions.
Absolutely.
It's
Absolutely.
and I think that's what drove a lot of Jeff's early work when he was developing his stuff out in Utah.
Right. I've always said that early on, EMS was very effective at integrating horizontally, integrating with each other.
Yeah.
But our vertical integration through public health and healthcare and physician communities and we were not as effective in that vertical integration.
Yeah.
And that our true measure of success would be when we did achieve that vertical integration and became a real part of that healthcare chain. And I think we're doing that. And
Yeah.
I'm encouraged by that.
Yeah.
I think all systems, my soundbite in Georgia was we aspire to have EMS systems that are physician directed, data driven, community based, and patient centered or people centered. If we'll do that with every system of care, we'll start seeing some real improved outcomes. We saw that we had a major issue with the infectious disease because of the because of Emory. We were and the CDC, and we were having so many potential Ebola patients during that 2014. Yep. Yep. So we treated infectious disease as a system of care, trained, specially trained medics, trained designated hospitals. We treated it just like we did any of the other systems, and it was the same thing. The interaction between the different players was what was going to determine whether we were successful or not.
During that period, 2014, 2015, with Ebola, I had the opportunity to train, to teach or refresh, I don't know how to put it, several thousand people in this part of the state.
Wow.
And I was astounded to see the donning and doffing procedures that went on.
Sure.
And I think you guys probably found the same thing up there.
Sure.
Because we had all gotten very cavalier about PPE and infectious disease communication and so on. Did you find the same thing in Georgia?
We did, and I said to groups as we traveled around, I said I had made it through the first 35 years of my career and never used the term donning and doffing, and then I'd used it about 10,000 times in a year.
Yeah.
But we went around to each hospital, to each region of EMS providers, and evaluated the donning and doffing, and the techniques were dramatically varied. Some
Yep.
not even close to the standards that the CDC was recommending. So yes, we absolutely, and that was we absolutely saw that, and we saw it as an opportunity to not only create a system that was good for our patients, but also good for our personnel.
Yeah, yeah. And I think it probably, the training we did during that period of time and the refresher training for people maybe has stood us in quite good stead now dealing with coronavirus.
Doug, I'm so glad you said that, because we tried to emphasize that at the time, that we are going to see a day when we will benefit from this, whether it be reducing healthcare acquired infections or whether it be addressing some other sort of outbreak. I said, let this be the foundation for our profession in preparation for what is yet to come. And so I agree. I think it has been a huge benefit to us now that we had those experiences, that refresher training, that reminder of how important personnel safety is, and protecting the next patient from the previous patient's
Sure.
infections.
Sure.
Absolutely. Great.
You mentioned earlier that after your retirement from Georgia, you did some work in Turkey. What were you doing in Turkey?
Well, I worked in Turkey in between my two times at Georgia. I spent 8 years in the private sector, and during that time, I managed a project for the World Bank, um, and disaster preparedness across all hazards, an all hazards approach. But the primary motivation for the World Bank was earthquake preparation. As you know from your experiences there, it's a very earthquake prone region.
It's a regular event.
Yeah, Turkey. And they had in 1999, they had a devastating earthquake, killed 25,000 people in the country. And so is Turkey a developing nation, an important ally in that region? The World Bank had an interest in preparing for another event. So I had the opportunity to manage that project, and it was the most interesting professional experience I ever had. That was 04 to 06, and I wouldn't trade it for anything.
Yeah, this Okona stuff is sometimes very rewarding and really eye-opening sometimes.
Oh, absolutely. It was living in Turkey was a life-changing experience.
Yeah,
no question.
So what's in your life now in terms of professional activity?
Well, I'm finishing my term as immediate past president of the National Association of State EMS Officials. I have a few more months in that capacity, and then we'll elect a new slate of officers, and I will rotate off of the board and executive committee of NEMSM. And I'm, as Christy mentioned, I'm on the board of the National EMS Museum and enjoying serving in that capacity. Good to be a part of that. So those are my two national EMS engagements right now. And after that, I'll explore other opportunities.
You thought about doing any writing on lessons learned over your career?
I think about that. I think about enjoying just being on my farm too. So I don't know. I'll always have a love and appreciation for the EMS and emergency management community, and there may be an opportunity for me to stay involved here in the state so we'll see.
So for now, it's staying on the farm and improving your golf game, huh?
Well, yeah, it's staying on the farm and avoiding COVID right now.
Yeah,
when this passes, life will resume to normal, and I'll be out and going to live music events, which is probably my favorite hobby,
cool.
and traveling around the South and the rest.
Well, if you ever need a place to stay down this way, I've got a guest room and a pool and the whole bit. So.
Well, you certainly live in one of the most beautiful regions of the country, that's for sure. The Panhandle of Florida is an incredible region and a gorgeous place. I have visited it many times.
Yeah, wonderful. Keith, thanks for the time. I'm going to ask Christy to look at that. She read my mind. She jumped right back in here. Look at that.
Finally got the cue down.
We'd like to thank you all for joining us this evening. And I have a feeling that Christy is going to do, and now a word from our sponsor before we go.
Yes, more like a big plea out to the world. We have a new newsletter getting ready to go to press. So if you are not a member yet of the National EMS Museum, I hope you will take the opportunity this weekend to check that off your New Year's resolution list, wink, wink, and sign up at emsmuseum.org/support us and be included. We got some new membership cards, so I'm really excited to start sending those out, but I need members to sign up to send those out. So do that at emsmuseum.org. Keith, thank you so much, not only for tonight, but you have done a lot of help with some exhibitions that are in the works. So more of Keith's knowledge will be hitting the museum walls, if you will, later this year. So thank you all very much. Thank you, Doc, as always. And everybody, thank you for tuning in. Have a very safe but wonderful weekend. And we'll catch you in 2 weeks. The new schedule's coming out. So tune in social media and you'll see who's up in March.
Great.
Thanks all very much.
Thank you. Have a
Good
good
night,
night.
everybody. Enjoy your Saturday evening.